So in this session, I would like to actually focus on two very current topics in cancer care. And nothing is more current than the pandemic of COVID that we're all going through at this time, which is really changing our lives significantly. So like I said, I'm going to be talking about the impact of COVID-19 on cancer care. So COVID-19, as we know, is defined as an illness caused by novel coronavirus. Basically, it stands for severe acute respiratory syndrome, coronavirus 2. This was first identified in Wuhan city in China, and the first case was reported to WHO on December 31st, 2019. And in January 2020, WHO declared COVID-19 as a global health emergency. And very soon after, in March 2020, WHO declared COVID-19 as a global pandemic. And since then, this has been one of the most devastating pandemic, and we have not been able to get out of it yet. As of November 11th, 2021, more than 252 million cases have been reported worldwide, with more than 5 million deaths. In US alone, more than 47,000 cases have been reported, with little over 780,000 deaths. So with such a significant impact, there is a lot of advances have made in the treatment of COVID-19. The vaccine against COVID-19 became available for general use in December 2020. And since then, the use of vaccine has increased in both general population as well as in cancer patients. With this, I would like to actually talk about the impact of COVID-19 in patients with cancer. Since patients with cancer have compromised immune systems and are at very high risk for catching other infections, there is a big concern that cancer patient may be at a greater risk for getting COVID-19 and the complications from it, including increased chances of death. These concerns were true in the initial data, but however, with new data, the factors that have been most consistently linked with increased risk of severe disease and death in patient in cancer kind of mirror with those in general population. So with that, I mean male sex, older age, history of smoking, obesity, hypertension, heart disease, and diabetes are associated with higher risk of complications and death, with an exception of lung cancer and hematologic malignancy, where the risk of complications from COVID and death is higher than general population. Moreover, because many of the cancer patients are immunosuppressed because of the disease itself and chemotherapy, they actually are not able to shed they're not able to actually clear the virus that rapidly as immunocompetent people, and may remain infectious for a longer period of time and shed the virus for a longer period of time. And that may lead to development of multiple variants. So we do not know exactly the impact of COVID-19 on cancer patients so far. NCI has initiated a COVID-19 study in cancer patients called NCC-APS. The study is ongoing, and a full impact probably will be seen in some incoming years. So just to let you know, I think the biggest impact of COVID-19 has produced on the screening of cancers. Screening was most affected during this time. Between March 2020 and end of April 2020, the screening for breast cancer with mammograms, colon cancers, lung cancer, prostate cancer dropped by almost 80 to 90%. In June, it started to recover, but even now, the screening is actually about 20 to 30% lower than from pre-pandemic level. And the full impact of COVID-19 pandemic, like I said, on early detection is still not fully known. So we believe that maybe the cancer mortality may increase as a potential impact of COVID-19 on cancers. And that may be related to a few factors. And first of them is reduced access to the care. And initially that was because of the lockdown and shutdown, but also because of the fear of infection and reallocation of the resources, the access of care is limited. And we have seen that in screening. COVID-19 has also led to unemployment and the financial insecurities and insurance losses. And that also has led to the limited access to healthcare. And obviously social distancing and shutdowns have also led to the limited access to the healthcare. The second factor is delayed routine care, leading to fewer preventive visits, screening, abnormal test follow-ups, as well as symptom follow-ups. So as a result of that, patients are actually presenting at the later stages of the diagnosis, and that reduces the probability of survival. There are fewer treatment options available at this time because of reallocation of the resources. And many of the treatments have needed to be modified, again, due to the risk of infection and also possibly the impact of COVID-19 on general health of the patient and their loved ones. There have been delayed treatments, such as in the beginning of pandemic, many elective surgeries were postponed. The radiations and the chemotherapies were postponed. Less intensive chemotherapies were offered to the patients, again, to prevent any chemotherapy-related complications and the complications related to COVID-19. All might lead to potentially increased cancer mortality, although we do not know the full extent of the effect of pandemic on cancer mortality yet. So because of COVID-19 pandemic, some adjustments were made during the cancer care delivery. And the most important one was the emergence of telehealth. Both televisits and video visits are being widely used. In the beginning, the practice, and this was the guidelines provided by ASCO and other cancer societies, to limit the staging procedures and do only studies that would actually give us information to develop the treatment of the care plan of the cancer treatment. Some of the patients were able to switch chemotherapy from IV chemotherapy to oral chemotherapies so that they can decrease the visits to the clinics. We also try to reduce treatments that lower the blood count and increase the use of medications that will increase the blood counts and use antibiotic prophylaxis, again, to lower the impact of another health issues in these patients. We also try to use treatment that will require less frequent visits to the healthcare facilities. Many patients who were in deep remissions and actually getting maintenance therapy chose to stop the maintenance therapy during this time. Many healthcare facilities limited the visit of companions to the patients to the healthcare facilities. And all of them impacted the health of cancer patients in some way or the other. Later on, with the availability of wide use of screening for COVID-19, that actually happened probably in late April and May, we were able to bring many patients back to the treatment. And with availability of different treatment strategies and understanding of treatment of COVID-19, the rapid initiation of the treatment for COVID-19 happened in patients who were actually who were diagnosed with COVID-19 along with cancer. So in these patients, we started using remdesivir early on and used monoclonal antibodies early on to help them recover from COVID-19. But nevertheless, these adjustments were made, and the full impact is yet to be seen. I think many many services were greatly impacted and delayed during this pandemic. Most reported delays were seen in in-person provider visits, which were down by 57%. Imaging services were down by 25%. Surgical procedures were delayed or down by 15%. The other areas were also impacted, such as access to support services, including physical therapy and mental health care services, were also reduced by 20 to 25%. And we also saw a significant reduction in enrollment in clinical trials for cancer patients. Up to 60% of the research programs were halted and enrollments were actually reduced. On the other hand, televisits and video visits were surged by over 90%, which was in some ways good because with this patients, many patients actually adhere to their schedules and their appointments with the healthcare providers. So with that introduction, with the emergence of vaccination and availability of vaccine, I would like to quickly go over the guidelines for vaccination in cancer patients. There are multiple vaccines available right now. 3 of them are FDA approved in United States. The 2 are mRNA vaccine from Pfizer, BioNTech, and Moderna. And in US, J&J, and in the rest of the world, AstraZeneca vaccines use a different technology which carry adenovirus as a vector that carries a viral DNA. So these vaccines are extremely effective. The efficacy of these vaccines are never been seen before in any other type of illnesses, and they are perfectly safe. I just want to make sure that everybody understands that these vaccines do not contain any live virus or the part of the virus. These are synthetic vaccine and do not risk contracting the disease in immunocompromised or immunosuppressed patients. So these are completely safe. There are some side effects that I will discuss later, but overall, these are the safe vaccines and do not cause COVID-19. I cannot stress this enough because even today in my clinical practice, I encounter at least one patient who has not been vaccinated and hesitant to get the vaccine. So I just wanted to make sure that these vaccines are safe. There is a concern that the vaccine may not be as effective. Overall, these are quite effective. The recent data from European Society of Medical Oncology was presented in September 2020, which included a study of over 1,000 patients. And it proved that both mRNA vaccines are quite effective, up to 80 to 90%, which is almost parallel to general population, where these vaccines were almost 99% effective. They looked at the antibody response. They did not actually talk about the COVID-19 disease in these patients. However, there is data emerging to suggest that immunocompromised patients may have limited antibody response, particularly in the patients who actually have hematologic malignancies or getting treatment with monoclonal antibodies that actually work against many of lymphocytes or the markers that actually, or the molecules that improve immunity. So one of such drug is Rituxan. And in patients who have hematological malignancy or on immunosuppression therapy or getting monoclonal antibodies, their responses is blunted. And based on this, actually, NCCN, which is National Cancer Care Network, created a COVID-19 vaccine advisory committee. And this committee made some recommendations for vaccines. The biggest and the most important recommendation is patients with active cancers and those on the treatment should be prioritized for the vaccination since it is quite effective. Immunization is recommended for all patients receiving active cancer therapy. In patients who are getting bone marrow transplant or getting CAR T therapy, we recommend to delay the vaccination by 3 months, mainly because they may not mount a strong response to vaccine and may get a false sense of security. If not possible, then it's better to give vaccine than not. The eligible caregivers and household contacts should also be immunized whenever possible, as soon as possible. And the committee also supports the use of any available FDA-approved vaccine, whether it is Pfizer, Moderna, or J&J vaccine, to every patient who is eligible. NCCN also supports the mandate for healthcare workers that require, vaccinations. So now, with that, I'm actually going to talk about the third dose recommendation. And I think there is some confusion about it. Third dose is different than the booster. So the booster of COVID-19 is given after 6 months of the last dose. And that's when it is seen that the immunity from the vaccine is waning, and the booster is given to boost the immunity again. The third dose is different because in cancer patients and patients who have impaired immune system, such as after the solid organ transplant, mainly kidney transplant, they have shown that their antibody response to 2 doses of vaccine is not as robust. And after the third dose, their antibody response was as robust as in the other populations. So the third dose is recommended for these patients who may be immunocompromised. And the CDC definition for these immunocompromised population is patients with active cancer who are receiving active treatment, the recipients of organ transplant taking immunosuppressive medications, the recipients of bone marrow transplant within the last 2 years, patients who have primary immunodeficiency syndrome, which have congenital immunodeficiency syndrome, patients who have been on steroid therapy that may suppress their immune system, and patients with untreated or advanced HIV infections. So in these patients, CDC recommends that an additional dose of mRNA COVID-19 vaccine must be or should be administered at least 4 weeks after the second dose of the mRNA vaccine. The current recommendations are for the mRNA vaccine. The data about J&J and the AstraZeneca vaccine is not clear. And right now, the second dose of J&J is actually being recommended, but not completely for the same indication. The J&J second dose is recommended for booster, but not to improve the immunity. So I would say even in the patients who have gotten J&J vaccine, we're recommending to take mRNA vaccine at least 4 to 6 weeks after receiving the last dose of the vaccine. The CDC does not recommend use of antibody titers to determine who should receive the third dose. Anybody who is who qualifies according to the CDC guidelines as an immunocompromised patient should receive the third dose of COVID-19 vaccine. And patients who actually have received COVID-19 vaccine before, but still developed COVID-19, we still recommend third dose of COVID-19 vaccine after they have recovered from it and cleared from the COVID infection. So these are the guidelines from CDC. The vaccine response, even with additional dose, may not be sufficient to prevent infection in the immunocompromised patients. So we do recommend that even after receiving the third dose, immunocompromised patients should actually use caution and avoid crowds, large public gatherings, and limit contact with people outside their household, and especially limit the contact and interaction with unvaccinated individuals as much as possible. So even though vaccines are safe and effective, the efficacy may not be as robust as in general population. There are some side effects of the vaccination, and one has to keep them in mind. And one of them is lymph node enlargement. So the lymph node enlargement has been reported in about 16% of the patients who received COVID-19 vaccination with the mRNA type vaccine. This is completely benign and reactive and does not pose any risk to anybody. However, it may confuse the results of imaging, and especially in the early on in the vaccination days, many patients end up getting biopsies of the lymph node, mainly breast cancer patients who actually had mammograms and ultrasound and found to have lymph nodes and ended up getting the biopsy. So now the radiology guidelines are recommending to postpone breast imaging 4 to 6 weeks after completion of COVID-19 vaccine, if possible. If not possible, then we have to keep in mind that lymph node may be benign or reactive, and then repeat this imaging maybe 4 to 6 weeks after later. And then there is a very, very rare complication of post-vaccine thrombosis with low platelet count. It is mainly seen with the J&J and AstraZeneca vaccine, and it is fortunately extremely, extremely rare. This same complication is seen with COVID disease and much more common. So I would not recommend that anybody deters getting vaccination because of this complication. So in the end, our parting advice is still, now the vaccines are available, it is safe. So get screened. It is safe to resume regular cancer care screening and care. Get vaccinated. Vaccines are safe, effective, and the only way out of this pandemic. And continue to be cautious, wear masks, wash hands regularly, and be cautious about interacting with people outside the same household and people who are not vaccinated. And do resume your regular treatment and preventive care. And with that, I thank you all for your attention.